Perfect. All right. Just to make sure we have enough time, we'll go ahead and get started with our second speaker for today. So I have the pleasure of introducing Dr. Waseem Ahmad, who is one of our clinical gastroenterology faculty based at UCSF Parnassus campus. He completed his MD at Rush Medical College, followed by internal medicine residency and GI fellowship at UC San Diego. And luckily, we were able to recruit him up to the Bay Area to UCSF in 2022. And he sees patients across the breadth of general GI diseases. Among the GI fellowship, Dr. Ahmad is known for his calm, cool, and collected demeanor on inpatient service as well as in the endoscopy suite. And he has a genuine interest in sort of the development of fellows and our careers and is really enthusiastic for teaching endoscopy to fellows. He is one of the highly requested endoscopy slots for outpatient endoscopy teaching as well. His teaching prowess has also earned him the Junior Faculty Teaching Award this past academic year, and the award is voted on by all of the fellows in our program and given to a faculty member who demonstrated exceptional dedication to teaching and mentorship. So we're super glad to have Dr. Ahmad with us, and with that, I'll hand over the floor to him to talk about lower GI bleeding.
All right. Thanks, Lakshmi, and thanks for joining. Excited to work with all of you guys. It's always kind of an exciting time to start the academic year. And then, this talk should complement Colin's talk. I know Colin highlighted a lot of key principles with upper GI bleeding and hemostasis, which, I won't kind of reiterate, but there are some aspects that we'll kind of make sure that we go over when it comes to lower GI bleeding. Okay, and so the objectives of this talk is really management of patients with acute lower GI bleeding. So it's going to be a little bit more inpatient focused, and then also kind of highlighting the management of anticoagulants and antiplatelets during the acute GI bleeding period. So just to start off, causes of lower GI bleeding, you can see, there's a wide differential there. For us, especially as consultants now, it's not only about knowing the causes of GI bleeding or the differential of GI bleeding. You almost have to start thinking ahead. Namely, if you get a consult for hematochezia, you want to be able to break up this list into, okay, what really is the top 2 or 3 things that might be going on? Because that is going to impact, how urgent we may consider either diagnostics or intervention, or is this someone that we're going to supportively manage? And then also it's going to impact, kind of what we're relaying to the teams or our endoscopy nurses. So you can see on the list, diverticular bleeding probably makes up about half to 2/3 of the causes of bleeding, and it's probably one of the more common inpatient consults that you'll get. Other common causes of lower GI bleeding include ischemic colitis, AVMs, post-polypectomy bleeding, among others. We'll highlight a few of these towards the end about things that you may see on the inpatient side. So factors associated with poor outcomes, as you can imagine, if someone comes in with shock, hemodynamic instability, you're going to be more worried about something more life-threatening. Other things to keep in mind, if someone has many comorbidities or they're elderly, that patient is going to have less reserve for you to kind of sit on or decide on what to do. If someone's had a history of diverticular bleeds or a history of AVM bleeds, they're more likely to come back with lower GI bleeding related to this. And then others factors that might be more associated with volume status, so elevated creatinine, low hemoglobin, and syncope. So the way we'll kind of break up this presentation is things that you want to consider in the initial go-around, meaning the time you get that consult to the time that you see that patient, and then things that should be going through your head in terms of being able to triage, divert roles, and then also afterwards kind of going over the diagnostic strategy, whether it's us doing a scope or not doing a scope. So with initial management, things that we're going to really harp on: focused history and physical exam, resuscitation, and then coagulopathy and antithrombotic management. So for the history and physical exam, you're going to see as fellows, you are going to be busier this year than you were ever as an intern, ever as a resident. You're going to have a lot of pages from teams asking for recommendations. and then you're running around between rooms to go do scopes, and then your attending has questions for you. So it can be very, very challenging to kind of navigate all of this. And so being very timely and focused with the amount of time that you do have is going to be important when it comes to triaging these patients. So in terms of history, the things that you want to get from either the team that's calling you or a quick, review on Epic include a lot of the things that Colin had brought up for upper GI bleeding. So in terms of medical history, cardiovascular history, oncology history, renal comorbidities are all very important. If someone has decompensated heart failure, or say they just had an NSTEMI and now had drug-eluting stents placed, that's very important for us to know because that may impact, what we can or can't do from a scoping standpoint. Someone has active cancer or currently being treated, that may impact what we do, whether, it's even offering a scope or not, or kind of discussing with the team what the durability of some of the hemostasis that we can do can be important. Renal comorbidities, which may highlight some of the issues that can come with antithrombotic management or the anticoagulant management. As Colin mentioned, knowing prior surgical history or radiation history is critical. You never want to be caught blindsided when you're going in for a scope. And so one of the easiest things that you can do for any consult, let alone a GI bleeding consult, is you can click on the notes tab and then go into op reports. And if they've had their care here at UCSF, you can see, have they had a bariatric surgery? Have they had a colorectal surgery? Where is the anastomosis located? These things can be very helpful, especially if we're thinking that that may be a source of someone's GI bleeding. Prior GI bleed history, as well as their procedure reports. Again, if it's been done at UCSF, look through the prior reports. When it comes to lower GI bleeding, especially, whether it's diverticular bleeds, radiation proctitis, AVMs, often these things will bleed again. And so knowing, okay, what did they find the last time? Where was the source? That can help us with the game plan about, what to do when we do want to scope this patient or, other diagnostics. As Colin mentioned, pertinent medications and last dose. So aspirin, antiplatelets, anticoagulants. You want to run through their medication list, even if the medicine team hasn't been able to, go through a med rec with them. Also, when you interview the patient, you want to know when's the last time they've taken any of these medications, because if you have someone that's stable and they've just taken their DOAC that morning, you're going to consider maybe being a little bit more conservative versus if it's somebody that just took it and now they're looking like they might be going to the ICU, then you have to start thinking about, reversal agent or other supportive measures. And then lastly, GI symptoms, if you can get somewhat of a history in terms of their symptoms, that can be helpful. If you have someone that's pouring out a lot of bright red blood, but they are not complaining of any abdominal pain, well, your suspicion of diverticular bleed goes up a lot higher, and then your management strategy may be a little bit more focused towards this. If you have somebody that is, kind of in the ICU, they're hypotensive, they're claiming of abdominal pain, their exam is tender, their lactate's going up, well, this may not be diverticular bleeding. Now you're thinking, maybe ischemic colitis, for example. And so, again, the whole point of having a differential is not that you can list off 10 different things for lower GI bleeding. All of you guys should know that, and we'll learn that very quickly. It's more about triaging this, because that is not only going to impact what we do medically, but also impact what we do from a procedural standpoint. Physical exam, most of the exams can be based on volume assessment, abdominal exam, and rectal exam. So volume assessment, as Colin mentioned, is huge. For any of these patients that are kind of borderline, blood pressures, 80s, 90s, they're tachycardic, you have to get them resuscitated. And you'll see that, when you do a case and if they're not adequately resuscitated, the second, you give moderate sedation or anesthesia gives propofol, they're going to tank and you're going to run into the issues. So before we can scope, I know a lot of times the teams will ask, okay, when can you scope this patient? Your answer has to be get them resuscitated, get them, adequately situated, whether it's in the ICU or if it's on the floor. Then we can think about, mobilizing and going ahead with an endoscopy or colonoscopy. Abdominal exam, like I mentioned above, is any concern for, ischemic colitis or something else that doesn't line up with, a classic diverticular bleed. And then, as Colin mentioned, a rectal exam. You're going to be called on every color of stool, and to be honest, most of the time it's wrong or it's not 100% accurate. So the easiest thing for you to do is do your own rectal exam, or at least look in the commode when you go in the room, because that will tell us, is this true melena? Is this hematochezia? Is this maroon stools? And the reason that that is important is the color of the stool and potentially the tempo of bleeding will impact, things that we're going to consider, or, both from a lower GI bleed standpoint, but also to think about maybe a fast upper, or is this not a lower GI bleed? Is this more proximal? So resuscitation, like I mentioned, this is vitally important. Anybody with hemodynamic instability or concern for ongoing GI bleeding have to get them IV fluids. And then the goal is to get their blood pressure and heart rate optimized before we're thinking about scoping. As Colin mentioned, restrictive strategy for PRBC transfusion holds for lower GI bleeding as well as upper GI bleeding. Our goal, hemoglobin, is 7 for hemodynamically stable patients. If it's an acute cardiac patient, it may bump up to 8. Again, you don't have to go over the top. The goal is to get them to 7 before we start thinking about intervention. Now, the part of this talk that can also complement the upper GI bleeding is what to do with coagulopathy and antithrombotic management. So for us, when it comes to like vitamin K antagonists and you get like a high INR, what to do. Often we'll run into this in the situation of someone that is on Coumadin for cardiovascular issues and then their INR shot up, or you may have a decompensated cirrhotic patient and their INR is up. What do we do in terms of bringing that down? Well, from a interventional standpoint, you want to ideally try to get the INR below 2.5. Number one, that's going to be safe. And number two, it's going to give you the best shot at winning when you're going to do hemostasis, whether it's putting on a band or clipping or coag. If you are in a situation that, hey, where you have to scope a little bit more urgently and you do need to reverse the INR, data shows that using Kcentra is better than using FFP, not only from a time standpoint, but also a volume standpoint. DOACs, and I'll show this on the next slide, there are targeted reversal agents in the setting of life-threatening GI bleeds, whether it's dabigatran or some of the other 10As like Xarelto or Eliquis. Commonly, we will not use this. Most of the times you can get by with just resuscitation and just holding the DOAC agent. But if you are in a situation that somebody's going into the ICU and it's all hands on deck, this may be something to consider with the ICU pharmacist about whether there's a role of doing this or not. And then coagulopathy, same thing with the INR. You want to optimize as much as you can control. And so if this is somebody who you can get their platelets above 50, that is going to be the best for us when it comes from a therapeutic standpoint. Obviously, there's going to be some cirrhotic patients or ITP patients that, you can do your best, but their platelets will never budge below or above 20 or 30. In that situation, what I would recommend is, giving them, platelets to at least be running during the procedure. Because again, anything that we do, at least from a scoping standpoint or procedural standpoint, is really based on giving us the best chance for hemostasis. And one thing I'll always tell the fellows is once the scope is in our hands and it's scope is in, it's on us. And so everything that we can tee up beforehand, we want to get addressed. And it's on us that, we didn't think about, optimizing some of these other things. So just something to keep in mind when you start getting these consults, looking through the blood counts and vitals before you, say yes or no to a scope. Aspirin, usually after you get hemostasis, okay to continue for secondary prevention. Other antiplatelets, kind of dependent on the kind of situation and whether you got complete hemostasis or not, but ideally you would hold initially. And then the last part is if someone's had stents placed, especially within the last 6 months, if not year, just talk with cardiology just to get their input about, is this something, can they hold their ticagrelor or do they want it to continue? And then, if it is somebody that just had like NSTEMI and now is on drug-eluting stents, this may be someone that you're just going to continue. So again, having them on board can be very helpful. This slide kind of gives a pathway of maybe what to do in acute situations, depending on what agent someone's on, whether it's Coumadin, dabigatran, or the factor 10As. In reality, like the bottom part says, most lower GI bleeding on anticoagulants can be managed with fluids or blood products and holding the drug. With Coumadin, like I said, Kcentra is probably the one that we can go with. Dabigatran or the factor 10As. To be honest, I haven't had to use either of these reversal agents, but again, if someone's going to the ICU and you're worried, this may be an option in those select cases. All right, so all of that is kind of setting the stage, and again, a lot of this is being done simultaneously. So you are talking with the team, you are telling the ER, get blood products going. We'll reassess at a certain time point, and that can work. But in the back of your head, you're also having to run a simultaneous thought about, okay, they're working on this patient medically, but then where do we come in from a GI procedural standpoint and whether it's appropriate or not? And so out of all the slides, this is, you're going to have to memorize this slide and this algorithm, but it's very kind of cut and dry about which way to go about things. So someone comes in with severe hematochezia, and usually that's somebody that is, really kind of pouring out blood, has come to the ER, is hypotensive, or it's somebody that has just dropped their pressures and is headed to the ICU. It's going to be that patient. It's not going to be the patient that has noticed a little bit of blood and now just walked in, or somebody that, had dropped maybe 2 points in their hemoglobin, but they otherwise look walkie-talkie. So for that patient, again, fluid resuscitation, get their hemoglobin above 7. If it's a really, fast bleed and they're going to the ICU and hemorrhagic shock, you do need to think about rapid upper GI bleed. And so always keep that, on your mind. So the easiest way to start would be on the right side. So minor lower GI bleeding. So for that patient, usually you're not going to get like a CTA. That patient's going to get admitted to the floor. What I would recommend for that patient would be going with a non-urgent colonoscopy, and we'll kind of talk about, do we even need to do a colonoscopy in certain situations? But that's the patient that you're going to tell the team about, okay, put them on clears, get them resuscitated, give them blood if they're, around 7, and then likely do a bowel prep for a plan for a colonoscopy the next day. On the other hand, if you get somebody who you're worried about, you get that 7 p.m. consult, somebody's bleeding, you don't know where their disposition is going to be, whether it's the ICU or, do you have to come in for scoping? That's the patient you're going to get a CTA for, or you should recommend a CTA for. And then we'll talk on the next slide about what to do based on that CTA. All right, so the role of this imaging is specifically for this case, the hemodynamically significant hematochezia event. CTA should be the initial diagnostic test. You're going to get a lot of calls from like the ER. Someone's pouring out blood, they're worried, they haven't resuscitated the patient, they're calling GI to consider a scope. What you need to do is, just go back to the basics, get them resuscitated, get their blood count going, and then if it's someone you're worried about, get the CTA done. Now, if on imaging it shows active extravasation, that's the patient that they need to call IR for consideration of embolization. If IR gets called early, you're going to get better outcomes. And for us, a lot of times we're going to get called about these, rapid or significant hematochezia events, and they're going to think that we're going to do a colonoscopy, come in and save the day. The data actually doesn't show that us going in with a scope for that select patient is really going to change things. And so knowing what our guidelines are very helpful about what is appropriate triaging or management. Now, what is the role of colonoscopy? Okay, so if someone, say, they came in, they got the CTA, came back negative, you're still kind of worried about them, that's the patient that you're going to start a bowel prep. Now, depending on someone's kind of ability to do a prep, you may consider having the team place an NG tube and doing a bowel prep through there. If it's somebody who's a little bit more stable and is going to the floor, then having them go on to a bowel prep and planning on a colonoscopy. The key thing here is it's non-emergent. So you are not doing a colonoscopy that evening. So if you get called at 6 p.m., someone's bleeding, and now the question is doing a scope at 8:30 p.m., that is not going to really change anything when it comes to outcomes such as rebleeding and mortality. So knowing this, it allows you to give the team, appropriate things that they can work on that evening, but then also gives us a chance to really optimize everything in case we do need to scope the following day. So if we do elect to, say, proceed with, doing a colonoscopy, you're going to tell the team to do, 4 to 6 liters of bowel prep if they can do it, whether it's split base like you would do for an outpatient scope or low volume prep, either are acceptable. Unprepped evaluations or routine flex SIGs are usually not recommended. I will say, and we'll go into this towards the end, about if you know that the source of bleeding is distal. And then, for example, if somebody came in early in the morning and they have a history of radiation proctitis, or say somebody just had a colonoscopy like a day prior and they took out a big rectosigmoid polyp and now they're coming in with bleeding, that patient, you may be able to get away with doing, tap water enemas, doing a flex sig because you know where the source is. But in general, if it's someone that's stable, going ahead with doing a full bowel prep is the way to go. There's always also going to be the question about, okay, if someone is stable, do we need to repeat scope them or not? And we'll kind of go over some diagnoses that, you need to consider about, is it really, needed to do a repeat colonoscopy, especially more on the inpatient side. So the final kind of aspects of this talk are to go over some more the inpatient diagnoses that you may see. So again, on that differential that we went over, there's like 10, 15 things on there, but you're not going to see all of those in the acute inpatient side. And then even so, you're probably not going to do anything about it other than supportive management. But for some of these, you do have to keep in mind, because these are the ones that you're going to get called about more in the acute setting or more on the inpatient consultant side about, hey, this is something that you could intervene on and kind of not something that you can wait as an outpatient. So diverticular bleeding, this occurs when an artery in the neck or dome of a tick ruptures. Again, this is going to make up about half to 2/3 of your acute lower GI bleeding cases. Clinically or based on history, it's usually painless, brisk passage of red blood and clots. With that said, if you have somebody that has just right-sided ticks, and maybe it's not as fast as it is on the left, then you could have maroon stools or melenic stools. So again, don't get phased out just by the color of the stool. You do need to take all aspects of the presentation on hand. Big thing to know is about 75 to 80% of these cases are going to start and stop on their own. Likely what happens in most cases, and we're used to this, is that someone's at home, they bleed a ton, they come to the ER, ER calls you. By the time you see the patient, they're not having any more blood and they kind of look okay. And so now you have to kind of decide, well, how do you play this out? You have this patient that likely had a diverticular bleed, but now it's stopped. Do you just monitor? Do you plan on doing a colonoscopy? Do you get a CTA? So these are things that you have to think about. Um, it is important to know if someone's had a diverticular bleed in the past, they're very likely to have a recurrence, anywhere from a quarter to a third within the few years that follow. What I would say is if someone's had a history of multiple diverticular bleeds and you know that in the past has gotten, a CTA with embolization, or they just had a colonoscopy, you already know what their colon looks like and everything else, bad has been ruled out. That might be a patient that you could probably just monitor. If you don't know anything about their history or you don't know their scoping history, then usually that person, maybe you'll have them admitted and bowel prep, and then you can reassess. It's never wrong to do a bowel prep. And then the question about whether to proceed with a colonoscopy or not, you can almost wait till the next day and decide. So again, when you're kind of assessing these patients, it's not only about medically what could be going on, but you also need to think about, okay, where is this going in a 6-hour time frame? Where is this going in a 24-hour time frame, 48-hour time frame? The more you can think about where things are headed in these kind of time points will allow you to kind of manage these patients with an expectation of good success. On the right side, this is from DDCEP, and we'll show a quick clip on the next slide where you can see a little bit of blood emanating from a tick. And then, in this case, the endoscopist placed a few clips in a zipper-like fashion. All right, so what does this look like for us when you do a diverticular bleed? So first things first, if the patient's not really adequately prepped, then all you're going to see is a bloodbath. So this is more, ideal situation where the prep quality looks okay. And really what you're going to do is you'll go in and you're just going to, wash off tick by tick by tick. And then hopefully you'll be able to see a little bit of bright red blood that's coming from an area. It's very easy to get kind of reflux of blood that can kind of make things challenging to know, is there actual bleeding that's happening or not? Again, what you want to do in these situations is be very methodical. It is an exhausting case potentially. You're going to be in there for 45 minutes, an hour. But you do have to go one by one. Other things that can help you if you are entertaining a diverticular bleed is when you go in, do you see like a clot somewhere? Do you see like an area where a little bit more pronounced red blood? And you do want to spend your time a little bit more focused in that area. The other thing just to keep in mind is, say someone probably bled from an area, but you're not 100% sure. Sometimes just placing a clip just for marking can be very helpful in case someone comes back again with a bleed, even if it's that hospitalization or soon later, because that patient, the next time you get called on them, you're just going to recommend getting a CTA because where they bled once is where they're more likely to bleed again in the future. All right, so the next kind of inpatient type consult you may see is radiation proctopathy. That said, this is usually a little less acute compared to diverticular bleed. These patients, you'll kind of know that they've had a history of radiation, whether it's from a history of bladder cancer, cervical cancer, rectal cancer, prostate cancer. Usually with these patients, it's not going to be their first go around for rectal bleeding. Unfortunately, once you get radiation proctitis with bleeding complications, sometimes, they're going to have to get 2 or 3 interventions to get everything under control. As Colin showed, APC is what's done, and I'll show a clip on the next slide of how this is done endoscopically. But usually what you're going to do is target individual vessels. In some cases, when we do these procedures, you're just going to see, a few discrete blood vessels, and then you'll just target those specifically. Other times, just like on the picture here on the right, is that you're going to have tons everywhere. Big thing to know is you can't just, zap the whole rectum and think you're going to be done with it. That's going to cause scarring, and that's actually going to cause more complications down the road. So in these cases, what you're going to actually recommend is, target the biggest blood vessels, get things under control, and then you're going to bring them back, say in like a month, and then repeat the intervention. Adequate bowel prep is necessary in APC. It is one of those situations where you do want to have as clean of a field as you can get. Sometimes even tap water enemas is enough to clear things out, but I would recommend at least giving something prior to considering APC for radiation. So what does this look like? All right, so you'll get somebody, depending on how bad their radiation is, you'll see, a certain level of kind of AVM distribution. So in this case, what you can see here is this patient has a ton of AVM, so this is very diffuse. What is good in this case for the endoscopist is that the whole colon is relatively clean. You don't really see any stool. You have clear liquid matter, so it gives you a good kind of working space. And so now that you're in here, everything is distended, your space is pretty clear. Now you can go ahead and pass the APC probe. And then essentially what you're going to do is you'll pass the catheter. You're not going to touch the mucosa, but you're going to just slightly kind of hover above. And then, as Colin mentioned, you'll step on the blue coag pedal, and then you'll zap. So this is not like bipolar coagulation where you're pressing against the mucosa and counting down to 10 Mississippi. You're just hovering over, one quick zap, and then you'll kind of see how this plays out. Again, depending on the distribution and like how many of these AVMs that you see, that'll kind of dictate how many you're going to do in one go around versus kind of bringing them back. All right, and then the last two diagnoses I want to go over. So ischemic colitis, this again is a consult that you're going to get. Often it's someone who might be on the surgical service, might be somebody in the ICU, and now they got a CT, and the radiologist is saying that there's thickening in like the hepatic flexure, splenic flexure. They're having a little bit of blood in their stool now. Question is, what do you do? So usually this doesn't make up that much of lower GI bleeding cases. And if there is a question of ischemic colitis, often colorectal is going to get called first. Management is supportive treatment. If they're in shock, treat the shock. Clinically, it's difficult to know, like, okay, is this patient going to have abdominal pain, or are they going to have GI bleeding? Usually for us, we're not going to scope this patient. We'll probably just say manage supportively. The one case that you may want to consider doing it, and this is usually with discussion with our surgeons, is if it's somebody that they may think about taking to the OR, then go ahead and plan on doing a scope. I've had, I remember as a fellow where it's, if you're in communication with colorectal and they have an OR ready to go, and if you go in and it looks like ischemic bowel and they're going to take them to surgery, then that should be enough for us to go in. So again, communicating with us in IR, us in surgery, us in the ICU is very important. On the right side, sometimes when you do go in and you do see ischemic colitis, you're going to see something called the stripe sign. Again, this is more of a buzzword thing and less opposed to a GI bleeding kind of situation. But if you do a scope and you see this, then you feel a little bit better about the diagnosis. And then the last one I did want to show is probably the one that we would actually scope and is the most acute, surprisingly. So again, we talked a lot about, hemodynamically significant GI bleeding, which you're thinking about a fast diverticular bleed, which you're going to get a CTA, maybe get IR, and then if that comes back negative, you're going to prep, and then probably the bleeding has stopped. And then everything else, whether it's, post-polypectomy bleed, ischemic colitis, radiation proctitis, might be a little bit slower that you can prep and scope the next day. Solitary rectal ulcer syndrome is the one that this can bleed and it can bleed fast. And it can bleed to the point that somebody is going from the ward to the ICU and they actually may need us to scope. And so in this case, you kind of see like right here, it's like you see like let me just bring this back again, is that there's a visible vessel within an ulcer in both of these. And for us, we get a lot of consults from teams that have patients that just had surgery, they're bedbound or they're in the ICU, they have a rectal tube in. And the thing with, these bleeds is when they go very, very fast. And so the chance that you may need to do like an intervention, whether it's, clip, coag, you name it, this is the person that you may have to go middle of the night to do a case. It's not wrong to get a CTA, and then depending on if it's positive, getting IR for a consult. But usually because these are so far distal, what radiology in my experience will say is, well, it looks like it's so distal, ask GI to see if they can reach it. And I would say I remember two memorable cases with Donna and Afshin that legitimately patients normal on the floor, and then they're in the ICU like within an hour, and we find some pretty crazy bleeds. So with that, I think those are the big ones on the inpatient side to keep in mind. Overall, a lot of this talk is to complement Colin's portion, which really highlighted the key things, not only from a hemostasis standpoint about all the tools that we have. Those are going to be, common between both, but also just the basic principles. I think what I would encourage for all of you guys, and I listed the references here, is that you're going to have your book learning. You're going to have to know all the ACG guidelines, AGA guidelines, ASGE, depending on what service you're on. The faster you can learn these guidelines, or at least have it for reference, then the easier your ability to triage and doing these consults will be doing. The other things that I would recommend or encourage that you guys do from the beginning is you really have to be an active learner for yourself. So I think gone are the days that you're just going to be handed everything to you in a book and you're just reading everything. So what I would encourage you to do is if you see something, look it up, whether it's up to date, AI, the easiest way of learning, probably the fastest way of accumulating knowledge and like kind of clinical skills, in my opinion, is just read through the consult list every day, regardless of what service you're on. Because you can see what's being done on the inpatient side on a day-by-day standpoint. And then not only is that important about decision making, about, okay, somebody came in with a consult, what is my first year co-fellow doing today? But you can see how does day 2 play out? How does day 3 play out? How does day 5 play out? Also, what does colorectal write in their notes? What does IR write in their notes? The more you can anticipate about what we're going to do, what the other services are thinking about, the better you get at seeing like where all of these little parts will fall in. So again, I think it's an exciting time. The beginning is definitely very, it's kind of drinking out of a water hose again, but, you guys are ready to go. And so like Colin said, we're all here excited and ready to help everyone. So with that, can take any questions.